Bismillahir Rahmanir Rahim. So today we are going to discuss a very important topic, that is poisoning. And the problem is when the patient is brought by some other people and you are not sure what is the history of that patient. And let's suppose the patient is brought to you by 1122 and you do not know the history and he is being poisoned. So from the clinical point you are going to diagnose which poisoning is this. So you are having benzodiazepine poisoning, opiate poisoning, and the organophosphate poisoning. So starting from the head to toe, pupil. In benzodiazepine poisoning, the pupil are normal sized. In the opiate poisoning, the pupil are the pinpoint pupil. In organophosphate poisoning, there is again pinpoint pupil. There is a parasympathomimetic effect. What is the effect on the respiratory rate? So in the benzodiazepine poisoning, the respiratory rate is decreased. It causes respiratory depression. In the opiate poisoning, it again causes respiratory depression. Respiratory rate, for example, say 5 per minute or 8 per minute. In the organophosphate poisoning, you are having increase in the respiratory rate. This increase in the respiratory rate is because of the bronchospasm and because of the secretion lying in the chest. So the person is having hypoxia and CO2 retention that leads to the activation of respiratory center in the brain, and the person is having increased respiratory rate. In benzodiazepine poisoning, the secretion and the sweating from the nose, from the mouth, and the sweating, there it is normal, or you can say that is depressed. In the opiate poisoning, that is also normal or depressed. But in the organophosphate poisoning, there is increased amount of acetylcholine, and on the sweat glands that are controlled by acetylcholine. So there is increased secretion and increased sweating. So increased acetylcholine causes increased nasal secretion, increased oral secretion, increased secretion from the eyes, and increased lung secretion. The lungs are full of secretion. There is bronchoria, you can say, and acetylcholine effect on the airways, bronchospasm. Wheeze. Benzodiazepine wheeze is absent because the airway they are normal. Again, in opiate poisoning, the wheeze is absent. But what happens in organophosphate poisoning, the bronchi, they are under the control of parasympathetic and sympathetic. So the acetylcholine, it causes bronchospasm. The sympathetic causes bronchodilation. Parasympathetic causes bronchospasm. So there is a wheeze. But if there is a very severe condition, so there is no movement of air. If there is no movement of air at all, there will be absent breathing. So absent breathing is a danger sign in asthma as well as in organophosphate poisoning, because there is no movement of air at all. Urinary and fecal incontinence is not there in benzodiazepine poisoning. It is also not there in opiate poisoning, but that is common in the organophosphate poisoning. That is, what is the parasympathetic effect on the urinary system? Increased urination. What is the parasympathetic system on the fecal system? Defecation. And also the sphincters are relaxed. The heart rate is normal or low. In opiate poisoning, again, it can be normal or low. But in the organophosphate poisoning, there is severe bradycardia. So the person is severely bradycardic. So what is the management? What is the management of benzodiazepine poisoning, opiate poisoning, and organophosphate poisoning? Well, for the benzodiazepine poisoning, management is supportive. You give the black tea without milk, you give the coffee. The purpose is to give the stimulant to the patient so that the drowsiness is improved. While what is the role of flumazenil in case of benzodiazepine poisoning? Well, this is the specific antidote for benzodiazepine poisoning. But what is the role? Point number 1, it is not easily available. Point number 2, it is very expensive. Point number 3, it causes withdrawal seizures. Now, how? If the patient is on benzodiazepine for a very long time and he presents to you with the benzodiazepine poisoning, his brain was adapted to the specific concentration of benzodiazepine. Now, when you give the flumazenil, it blocks the effects of benzodiazepine and there is withdrawal symptoms and there is seizures. So the patient presents with seizures. Contrary to that, if the patient is not taking the benzodiazepine on a long-term basis, so you can give flumazenil because it is acute poisoning and you can give flumazenil safely. But again, It is not easily available, it is not cheap, it is expensive, and the benzodiazepine does not kill the patient. Benzodiazepine does not kill the patient, so the treatment is supportive, provided that you are clear regarding the diagnosis. If there is something going on with this, then this is not that much safer diagnosis. For example, a patient is asthmatic, he is also at risk of respiratory failure, and benzodiazepine is causing again respiratory failure. So you have to look for the comorbids from the pulmonology point of view and from the metabolic point of view. In the opioid poisoning, injection naloxone every 5 to 10 minutes until there is pupillary dilatation. But the half-life of opioid is very long as compared to the naloxone, so you have to give repeated dosing. So we admit the patient and monitor the patient, because if we give 5 injections of naloxone and we discharge the patient can again come with the poisoning. Let's suppose we say the half-life of this is 20 hours and the half-life of the naloxone is 1 hour. So if you are giving 5 injections of this, so you can give coverage for 10 hours, but for the rest 10 hours there can be again the recurrence of symptoms. So you have to monitor the patient for the recurrence of symptom. Half-life versus short half-life versus long half-life. Coming toward the organophosphate poisoning, we give atropine and pralidoxime. What is the difference between the two? We give in emergency both, but atropine, it cannot reverse the muscle weakness. This is the key point. It cannot reverse the muscle weakness because there are no receptors for atropine at the muscle. But the pralidoxime reverses it. So if the question asks, this is for MCQs purposes, if the question clearly says that there is muscle weakness as well, so you have to pick the pralidoxime then. Atropine does not recover the muscle weakness. Best initial is atropine, most specific is pralidoxime. But if the question asks what can you do for a muscle weakness in a case of organophosphate poisoning, your answer is pralidoxime. Your answer is pralidoxime. So how you give atropine? You give 1 ampoules of atropine IV fast every 5 to 10 minutes until there is atropinization. Atropinization means the heart rate is increased and the pupil size is increasing until the normal physiological levels are achieved. But when will you stop atropine? When the heart rate is more than 130. You have to miss the dose. And pralidoxime, you have to give it in continuous infusion. Regarding the dosage, I will make another video. So thank you for this.